I'm going to go over the panel on the front of the oscillator. The mean airway pressure display window is in the top left. The amplitude display window, and then this is changed by the power knob, the pressure limit, the mean airway pressure adjustment, and then the bias flow is the liters per minute that are set. It can range from 8 to 20 liters per minute. The I-time percent adjust knob in the display window. Typically, this is going to be at 33% and is rarely changed. Frequency adjust knob and the display window. This is where you will read your hertz. On the left-hand side with the two rotary dials is where you're going to set your minimum and maximum mean airway pressure. So some contraindications to the use of the oscillator. If there's an obstructive airway disease, using the oscillator can lead to severe air trapping. Traumatic brain injury or intracranial hypertension, the high mean airway pressure can lead to decreased venous return due to the increase in the intrathoracic pressure. And if there's any hemodynamic compromise, especially if the patient is unresponsive to fluids and/or pressors. Initial settings: set your FiO2 at 100% and then titrate to your targeted saturation range. Your frequency, you can follow the table on the right-hand side. The lower the gestational age and the lower the weight, usually the higher the hertz. As the baby matures and gains weight, the lower the hertz. Amplitude or delta P. You're going to adjust this until the patient has a wiggle down to the groin. It should be even across the chest. Inspiratory time is set at 33%. How do you know if it's working? The patient's saturation should increase in the first 30 to 60 minutes of initiation. Make sure that there is adequate jiggling or chest wiggle that shows that the patient is being ventilated. Get a chest x-ray to confirm that the patient is not hyperinflated. And then be aware of changes in lung compliance, secretions, or if a paralytic is used. If the wiggle is decreased, check your ET tube position and consider suctioning. So unlike the conventional ventilator, when you decrease your frequency, you're actually going to increase your tidal volume, which means you'll blow off CO2. So on a conventional ventilator, where you would increase the frequency to increase the minute ventilation and blow off CO2, it's going to be different on the oscillator. So a lower frequency means that there are fewer breaths per minute. Your inspiratory time is set at 33%. So as the rate goes down, your I time is actually going to lengthen because of the 33% of the breath. So the I to E ratio is fixed at 1 to 2. So the slower the rate, the more volume of gas that is being moved. In the event of a circuit disconnect from the patient during movement and the piston stops, reconnect the circuit to the ET tube, press and hold the reset button. Once it achieves 20% of the set mean airway pressure, it will restart. So in summary, the oscillator is a useful ventilatory mode. It can provide lung protective strategies. It delivers an unknown tidal volume, so frequent blood gases are required. Make sure that the patient is wiggling. If it's not wiggling, you're not ventilating. To increase oxygenation, you can increase your FiO2 and increase your mean airway pressure. A higher amplitude, or delta P, equals greater ventilation. And once again, it's highly unlikely you will need to adjust the I time.